we're gonna start with, pathophysiology of different complications related to pregnancy. In order to do that, we're going to start with some videos, short videos. I think this is helpful in understanding some of the processes. The first one is kind of really, entertaining.
What?
The nutrient changes through that, which is pretty fascinating. And so when we talk about the placenta, it is that particular, organ, and it is an organ that becomes, that's absolutely integral for the baby to grow. So any disruption in the placenta or placental blood flow is going to have a negative impact on the fetus. Okay. The cervix, being the opening to the uterus. It's all very muscular. It's not as vascular. And so when we talk about placenta previa, you're going to understand when you have a low-lying placenta or the placenta is covering this os, you can see where that's going to be problematic. Okay.
Into your birth canal. Your doctor or midwife will instruct you.
Okay. So placenta previa. Okay, we'll start with that one. This is where the placentation where the placenta develops is near or covering the os. Okay, and as you can see here, okay, let's go back maybe. Okay, as you can see, this is normal and the placenta is high. Okay, that doesn't always occur. So normal, you have a higher placenta that develops to support the fetus. Okay. And so this is a low implantation. Sometimes that can be problematic. Sometimes it won't. Normally it's going to grow in the direction of greater blood supply. And there's lesser blood supply down towards that neck and towards the cervical os. So low lying placenta. This is a partial placenta previa where it's partially covering the os. And then you can have a complete or total placenta previa where the placenta completely overlies the os. And you can see where that's going to be problematic down the road for this baby. Okay, so complete previa is complete covering. A marginal previa is where the leading edge is less than 2 centimeters from the os, but not fully covering. Okay, and so what happens, okay, is there's a lot of things that can lead to the fertilized egg, the morula at that point, implanting at a lower segment. Okay, you can think about, and when it does, and the fetus grows, that placenta is going to grow with it. Now, if it doesn't grow towards the more vascularized area and it's really low implantation, it's going to cover the os, the placenta will. Okay. Again, defective vascularization occurs over the os, which then is going to be problematic for the baby, the fetus, once it gets especially into that third trimester. Okay, because that's when that lower uterine segment starts to stretch out more as the baby gets bigger, bigger, and that uterine wall gets thinner and more floppy and receptive for the baby's head and body to come through. Okay, and what that's going to do is lead to bleeding at that implantation site. Okay, and with that, you're going to trigger, clotting cascades. Thrombin is a strong promoter of uterine contractions. And so then it's going to difficulty to stop the bleeding. And as the things contract, the pressures are going to build up in those arteries, which will actually increase the bleeding. The A to the of the lower uterine segment can't contract. The contractions occur at the top, the fundus of the uterus, and work their way and to push the baby down. So you don't have that same contraction in the lower uterine segment. So you can't contract to stop the bleeding. Those higher contractions leads to increased pressures on the blood vessels, which is gonna lead to increased bleeding. And the thrombin itself will promote uterine contractions and premature delivery. Okay? And let me see if I can get this one to work. Down here. Exit. Created, once that placenta leaves, is delivered, it's gonna leave a scar in that endometrium. Okay, it's gonna leave a scar. And typically, that's no longer going to have, you know, the functional layer and be a good place for implantation. So the more pregnancies a woman has, the more essentially scars and inhabitable areas there are in the uterus for implantation to occur. C-sections, okay, and we have to suture it up and everything, it's gonna leave scar tissue. Any kind of intrauterine procedures leaves scar tissue. Abnormal shape of the uterus, like people who have fibroids or, you know, just abnormalities in the shape of the uterus, or have had myomectomies because of fibroids. That's gonna leave scar tissue, and it's gonna make for inhabitable areas for the egg to fertilize. And so it will find an area where there is that decidua basalis, and, you know, that is gonna become that functional endometrium that's nice and provides that and inviting environment for this egg to then implant, develop a placenta. And so it just, the more pregnancies a woman has, the increased risk there is of developing placenta previa. And yes, all those other things that they listed as risk factors, just think of it in terms of scar tissue and abnormalities that are going to make inhabitable areas in that uterine lining for the egg to implant. Okay.
Is the reverse also true, where you have media with scar tissue in the bone uterus, less likely to happen yet?
Yes, probably less likely, but at that same time, they're going to then do like, well, yeah, and then they'll do C-sections, which then creates even more. And yeah, so as women age and multiple pregnancies, you know, you go and have women who have abortions and D&Cs where they scrape the lining of the uterus, there's always the risk that that can precipitate a placenta previa, or some, you know, even if it's marginal. And, you know, and yeah, it's age. Age is a big factor. You know, a number of previous pregnancies is a big factor. Any kind of surgery or instrumentation of the uterus is a big risk factor. And yeah, less likely, but a lot of women, they'd be like, look, you know, depending. It doesn't usually happen on the first pregnancy, not usually. And so, usually it's like, okay, you probably don't want to have any more children, you know, kind of thing. Or try anymore because this is a bad sign. And so they're often kind of counseled not to get pregnant again. All right, let's see, what else? It's a good question. All right, placenta accreta. Okay, this is a spectrum of problems involving the placenta, in that the placenta actually grows into the endometrium, myometrium, etc. And when it does that, it doesn't detach in that third stage of labor. Okay, and so then because it's highly vascular, it becomes a source of bleeding. And yes, it is associated with high maternal morbidity because of the hemorrhage associated with it. It's relatively new disorder. And so, it was first described about 80 years ago, and yes, it's associated with previous pregnancies where they manually removed the placenta, which again is gonna damage that lining. Any type of curettage procedure like a D&C, even if it's for, thickened endometrium, or if it's for abortive purposes, and they do what they call dilation and curettage, when they scrape the lining of the uterus out. And then infections involving the endometrium. So that's what, those are kind of the big things that it's been associated with. And so it doesn't get extruded, that placenta, if it attaches there, it will actually grow into the wall of the uterus and lead, like I said, lead to that maternal hemorrhage. So there's normal, which is to your left, far left, accreta, increta, and percreta. Okay, that's the spectrum. Accreta, okay, accreta is when the villi adhere to the myometrium. So they go below that decidua layer in that basalis where all the blood vessels are. They go below that, and actually the villi, those anchoring villi, adhere to the muscle of the uterus itself. Increta is when it involves into the myometrium, and then percreta is the whole thickness of the myometrium. So I'm going to go back to the pictures there. So it goes from normal to accreta to increta, and then percreta is, it permeates through liver when in that third stage of labor. And so pieces of it will stick, or as the rest of it's delivered, a piece will be retained. We call that retained products of conception. And sometimes, and that can lead to significant maternal hemorrhage. Yes, Jalen.
That first word, since it's really tight, that first one, is that supposed to say accreta?
Accreta. I must have forgotten a day. You can put a day in. I'm gonna post this anyway with all the different links in it.
Okay.
Okay, so anyway, let's see if I can get this one to work. Okay, in order to make the other slide. Okay, it's a very serious, condition. And so it is important to identify it, and so you know what the risk factors are, and it has to do with the invasion of those, the myometrium of the, uterus. Okay, placental abruption. Okay, technical name for it is abruptio placentae, and it is when the placenta actually detaches prior to labor and delivery, prior to the normal birthing process. Okay, and usually we reserve this term for pregnancies that are over 20 weeks gestation. Anybody know what the age of viability of a fetus is?
Over 24 weeks.
It's like between 22 and 24 weeks, somewhere in there. It's a range because again, there's often variability in menstrual cycles and things like that. So between 22 and 24 weeks is age of viability. So usually we reserve this term for pregnancies after 20 weeks. And yes, these babies are fully formed at that point in time. Okay, and this compared to previa, this is typically painful bleeding, okay, as opposed to painless bleeding, which is what you get with previa. And think about this highly vascular exchange organ for that's linking mom and baby, and all of a sudden it starts to separate from the uterus. Okay, and so you're gonna have bleeding. What else are you going to have? What else is gonna happen?
No perfusion.
Right, exactly. So it's gonna deprive the baby of much needed oxygen and nutrients. So we have two problems going on here, okay? And so, you know, it's painful for mom's hemorrhaging, baby's not getting oxygen, okay? And so you're gonna see what we call a non-reassuring fetal heart rate pattern on the TOCO. So when you do the fetal monitoring strips and you look at their contractions versus what's going on with the fetal heart rates, which you're all gonna learn how to do, I hope. You know, you're gonna see non-reassuring patterns that are like, okay, this baby is in distress. Okay, and so placental abruption is a obstetrical emergency requiring emergency C-section. Okay, in order to try to save both mom and baby's life, because it can kill both. Okay, so the maternal vessels, typically it's the maternal vessels on the decidua side that rupture. And sometimes it can occur on the fetal side, but most commonly it's on the maternal side. And both arteries and veins can be culprits. Obviously, if it's an artery, it's gonna be a higher pressure, heavier bleed, lots more blood. It's going to be very apparent, okay? If it's venous, it tends to be lower pressure, and often at the periphery of the placenta as opposed to more central. And it's not as abrupt, so to speak. But both of them are problematic. Okay, and so what do you think causes that? Trauma. It's usually trauma related. You know, a car accident, seatbelt injury across the gravid abdomen. It can be direct blow, blunt force trauma, fall down the steps, things like that. And so all of those are, there are red flags for, your moms, your pregnant women. Let's see if I can get this one to work, and then I'll give you a break. Lead to thrombin production, and we already said that thrombin is a potent, it causes uterine contractions. It's gonna be a pro-contractor for the uterus. And the hypoxia that occurs in those decidual cells is going to stimulate vascular endothelial growth factor release, which then is going to stimulate tissue factor. Again, two pathways by which thrombin is being produced. And then again, it's going to increase uterine contractility. It's going to also increase what we call the matrix metalloproteinases. So these are enzymes that break down part of the matrix in there. And so it's also going to upregulate some of the genes triggering apoptosis of some of the cells and stimulate cytokine release, especially IL-8. And so what that's going to lead to is more necrosis and degradation within that intracellular matrix. And that it's going to trigger the coagulation. You got that we already said that. And that's part of your clotting cascade. And it's going to result in progesterone withdrawal because of number one, dead cells, and number two, a reduced expression of your progesterone receptors. And progesterone is necessary for maintaining the placenta in pregnancy. So all of those things combined are going to lead to the abruption. Questions on abruption? Yes, Sydney.
The video said that they're hypertensive, but they're hemorrhaging. So are they just hypertensive initially to try and like vasoconstrict,
Mhm.
and then once they can't, they got like, once they lose enough blood, they
Yes,
become hypotensive?
correct.
Okay.
Yes, exactly. So they become hypertensive initially. You've got the pain response, you've got your sympathetic nervous system kicking in, causing vasoconstriction, which is gonna raise your pressure. Vasoconstriction though, however, of these arteries, when you have a disruption, is just gonna lead to increased bleeding. Higher pressure will lead to the increased bleeding. And then you're gonna have blood loss, which then becomes hypotension. Once you lost a certain amount of your volume. The one thing in there that kind of bothers me is it doesn't lead to dehydration in the mother so much as it leads to volume loss, and it's whole blood volume loss, not water. Water dehydration is purely water loss. And so I kind of don't like the terminology there.
Yeah.
Because it's whole blood loss. Okay. Any other questions? Yeah, just bumping the steering wheel, pregnant woman driving. Doesn't even have to be high impact, but that big gravid abdomen hitting the steering wheel. Boom, can lead to an abruption. All right, why don't you take about 10 minutes and I'll see you at 10 o'clock. Amniotic sac is it ruptures prior to typically 37 weeks, which is considered full term, although we use 40 weeks as our general. And so it's before uterine contractions, it's before, the normal time frame of delivery. Okay, and yes, it does cause up to a third of our preterm births. And it happens in about 3% of pregnancy, so it is something you're going to see when you're on clinical site. Only about 0.5% will occur before 27 weeks. And then another 1% between 27 and 34, and 1% between 34 and 37. So obviously, the closer to the gestational due date, the better for the baby, okay? The problem we run into is underdevelopment, especially of the lungs. Okay, and so let's see. Guess not. Okay, we don't know. There's multiple reasons why this occurs. Right? There are multiple risk factors for it. Infection being one of them. Okay, think about what infection does. Okay, it's going to draw your inflammatory cells. They're going to release their cytokines. It's going to stimulate an inflammatory response. Okay, and that is then going to stimulate other release of proteases and destroy tissue. And it can break down that amniotic membrane, okay, and lead to the rupture of those membranes. So when you think that, know that all those membranes are really based on proteins and collagens and fibronectins and things like that from the extracellular matrix. Okay, anything, including those matrix metalloproteases and other cytokines, when released, can actually start to degrade collagen, can degrade some of these, they're proteases, so they're going to degrade some of the proteins that are the foundational structure of this connective tissue. Okay, and so whenever that occurs, it can lead to weakening and or rupture of these membranes. So like bacterial vaginosis, your Gardnerella vaginalis, other bugs, including STIs, they can produce phospholipases. Again, another enzyme that's going to break down your lipid molecules. Okay, it also stimulates prostaglandin production. and premature contractions. So, if people have had the premature rupture of membrane in the past, it's been a recurrent theme, there may actually be a genetic alteration in one of their proteins. Okay, and that leads to a weakened amniotic sac. And so that sac, once it's weak, it gets to a certain point and it just busts. Okay, antepartum bleeding, so if they have bleeding before they go into labor, that bleeding process is going to stimulate the release of thrombin as well as those metalloproteases. And we're back to that same process of breaking down the, structural integrity of the amniotic sac. Smoking, cigarette smoking, that is a risk factor. We don't know the exact mechanism, but we do know that nicotine itself collects in the cervical mucus. It's highly concentrated, which is one of the reasons it is linked to cervical cancer because of the high concentrations. And for some reason that is also a risk factor, although we don't know the exact mechanisms. Yes, Sydney.
This might be a dumb question, but
No dumb questions, okay? That, no question is dumb. You're here to learn.
when you say rupture of membranes, what is the membrane?
It's the amniotic sac.
Okay.
Okay, the fluid filled sac that the baby lives in. You have the placenta, and you have your fluid filled sac that, is the swim where the baby's kind of floating in and peeing in and swishing in.
Thank you.
Do you have a question now?
Yeah, they can, with smaller ruptures, can't it reseal?
It can, if it's a small rupture, it can reseal. If there's only a small amount of fluid, they'll do an
Yeah.
ultrasound, they'll see how much fluid is in there. And yes, sometimes they'll just put them on bed rest and try to see what happens. And as long as there's a certain amount of fluid, once the fluid level gets down to it's not enough, then they've got to deliver the baby. Any other questions? All right, now we're gonna move into all the different hypertension syndromes, okay? So there's hypertension, chronic hypertension, gestational. We have preeclampsia, eclampsia, and HELLP syndrome. These are all hypertension syndromes associated with pregnancy. The numbers are there diagnostically for what hypertension in pregnancy is. And typically we say 20 millimeters of mercury above whatever the patient's baseline blood pressure is. Okay. But anything 100, more than 140 or either systolic or diastolic is considered hypertension. You don't have to have both. Okay. Severe is there. Chronic is either it precedes the pregnancy or present on 2 occasions prior to the 20-week mark, or persists more than 12 weeks after delivery. Okay, that's considered chronic hypertension. So it's there before the 20-week mark. It's there before pregnancy, or it persists extended duration after pregnancy. It's then considered chronic. Gestational hypertension is very specific in that it's hypertension, no protein in the urine, or any other signs of end organ damage that doesn't develop until after 20 weeks of gestation, and then resolves relatively quickly following delivery. Okay, then it's considered gestational. the worst ones, we can manage those. We can manage all of those. And you're gonna learn which drugs are, you know, probably already, we learned which drug to use in pregnancy from Dr. Noel last semester. But preeclampsia, eclampsia, and HELLP syndrome are kind of the complicated versions of it. Okay, so preeclampsia is hypertension with proteinuria or hypertension with end organ damage, right, or dysfunction after 20 weeks of gestation or postpartum. So preeclampsia can even occur after the baby's been delivered. Patient may be symptom-free throughout pregnancy. After delivery, blood pressure goes up, starts spilling protein, or starts having other signs of end organ damage. Eclampsia is when the patient starts to seize. Okay, and does not have a pre-existing seizure disorder or anything else that would cause seizure. Okay, so it's along with hypertension and proteinuria, or this may be part of their end organ dysfunction. So that if they start to have seizures. And so we, sometimes when the pressures get high enough, we prophylactically give them magnesium, which is protective of the seizure activity in pregnant patients. And then there's HELLP syndrome. This is horrible. Right, this is a hypertension syndrome gone horribly wrong. Okay, and the HELP stands for hemolysis. So what's happening? Red blood cells are bursting, so they're going to become anemic, high levels of bilirubin. Okay. Blood pressure is going to drop. Is that good for the baby? No. They have elevated liver enzymes in addition to the high bilirubin, low platelets, so they become thrombocytopenic, and can actually go into liver failure. And they can die. Right, this is essentially a type of preeclampsia that has just gone horribly wrong where, for whatever reason, and we can't predict who's gonna get it. But they have severe, like these alternative features of hemolysis and, you know, and the liver enzymes go high. It's awful. We can't predict. Well, we always try to control the preeclampsia, but these actually, it's more of like a type of preeclampsia that occurs. And a lot of times it occurs around the time of delivery. And it can severely affect both the baby and the moms. And it just happens like out of the blue. They're fine one day and the next day, all of a sudden, they start having this massive hemolysis, high bilirubin levels, which is toxic to the fetus. Low platelets, they become hypoxemic, the baby, not enough oxygen delivered because of the hemolysis and the loss of red blood cells. And they've got to emergently deliver the baby. And yeah, it's terrible. So looking at the pathogenesis of these hypertensive conditions, you know, probably both maternal and fetal or placental factors will play a role. And so what they're proposing is that there are alterations in those spiral arteries that feed the placenta for the fetus. And so when that occurs, they become narrower. And because the terminal ends are normally wider to allow that exchange to occur, and as they become smaller, it restricts flow. And so when you get restricted flow, the trophoblastic tissues that are in there are going to experience a relative hypoxia because of the decreased flow, narrowed arteries. Okay, and that's gonna set off, that hypoxia is gonna set off this chemical cascade. And so essentially it's oxidative stress to the placenta. You have anti-angiogenic factors that are gonna bind with VEGF and PIGF, and which are going to inhibit the formation of more vessels. There is a lot of inflammatory changes. There are a lot of inflammatory changes that are gonna occur with causing endothelial dysfunction. And when you have that endothelial dysfunction, that's gonna trigger your clotting cascade. It leads to vascular injury. And all of that is going to lead, and all that's gonna lead to hypertension, proteinuria, and some of the other findings, including even in health syndrome. So this is kind of the probable or possible mechanism of what happens. So you start with this abnormal trophoblastic tissue. So you have these abnormal ends of your spiral arteries that are more narrow, which is going to decrease your placental blood flow, leading to placental ischemia. And then when you have ischemia, it's going to trigger that whole ischemic cascade with the release of inflammatory cytokines, etc. Then with your endothelial dysfunction, you're going to have a decrease in your dilating factors, increase in your constricting factors, increased sensitivity to your angiotensin II, and that's going to decrease how much natriuresis goes on because you're going to hold on to sodium, and all of that's going to lead to hypertension. And under perfusion of the kidneys, you're going to start to develop proteinuria. All right, so hypertension in pregnancy, we can use a beta blocker, okay, which then kind of blocks some of that vasoconstrictive effect. Okay, and again, decreases the effect of your beta 1, beta 2s, etc. Affects those. Okay. All right, ectopic pregnancies. So ectopic pregnancy means that the fertilized egg implants somewhere other than the uterus where it's supposed to implant and grow. Okay, yes, your fallopian tube is the #1 location where it implants. Okay, but it can be anywhere inside the pelvis. So I'm gonna break and tell you a story because I love stories and because, you know, you never know what you might encounter one day. So I was in the ER one day and I had this young woman come in who she had darker skin but she looked so pale. She just didn't look well. And she was feeling dizzy and lightheaded. and just didn't feel well. And she says, I feel like I'm still pregnant. I said, well, what do you mean? Well, story is, to make a long story short, she was pregnant and she went to New York to have an abortion done. Okay, they did the abortion. However, they never did an ultrasound, so they did whatever they did. They did a DNC is what they did. So they dilated, scraped out, suctioned, or suction DNC. And the contents of the uterus. And they never did an ultrasound, so they sent her home. And I said, so did anybody, like, did they say anything? I said, when was this? And it was like a couple months, like it was a while, right? And I said, what? I said, did anybody call you? Did anybody say anything? Have you been having periods? What's going on? She hadn't had a period since. And then she says, yeah, somebody called me and said something about I needed to come back because there was something, they didn't find something that they were looking for or something. And I'm like, and did you go back? No, I didn't go back. I mean, she was like, I was in New York, and I'm here. This isn't a Baltimore Metropolitan Hospital ER. And I'm like, this girl's pregnant. She's got an ectopic. And she's bleeding. I mean, she was so pale, like, she's got so I didn't even wait for the test results to come back. I called the OBGYN on call. I said, look, here's what I got. I'm waiting for all the testing. Well, go get the testing. I said, I'm telling you, she's got an ectopic and she's gonna bleed, and she's bleeding. She's losing blood. So anyway, I got her H&H back, and her H&H were like low, as I expected. I mean, she was so pale. And then her HCG, she was still pregnant. And then the ultrasound, she had a 20-week fetus attached to her colon. And it was bleeding. She went to the OR that night. And she had a 20-week fetus attached to her colon. Yes. Amazing, like unheard of. I mean, I should have written it up as a time, like I really should have written it up, and she lived. Obviously, the fetus did not. But of course, she ended up having to get, I don't know how many units of blood transfused. And so moral of the story is, you can't trust a lot of these abortion clinics, and whether you're, regardless of what side of the fence you are on personally, from a moral perspective, people are gonna go different places to have abortions if that's what they like to do. And the problem is, I'm not having regulated places is, and I can't say that I don't know what the story on this place was, but if things aren't done properly, these kind of bad outcomes can occur. And had I not had that, or she'd been diagnosed and taken to the OR that night, both she and the baby probably would have died. Okay. I mean, sets her up for DIC, the whole 9 yards. And so, you know, you got to really listen, and you got to kind of like trust your gut, trust your instinct on some things, because these ectopics can be anywhere. Okay, what did you learn about endometriosis? It could be anywhere. What is endometriosis?
Uterine tissue.
So it's ectopic endometrial tissue, right? It responds to the same hormonal stimulation that your period does, the menses, right? It becomes, you know, it grows, it's a nice fertilized, it's a place where a fertilized egg can implant. You can have these endometrial implants anywhere in the pelvis, the abdomen. You can even have it in the chest. Now, for a fertilized egg to get to the chest, that's a bit of a stretch. You know, you can have them on the pericardium or on the lungs. So. But in the peritoneal cavity in the abdomen, very, very common, it can happen because it is an implantable spot that is going to respond to those trophoblastic cells. So endometriosis is a huge risk factor for ectopic pregnancy. You can add it to the list. Anything that distorts or scars or restricts the tubes and for passage of that fertilized egg into the uterus is also a risk factor. So previous pelvic inflammatory disease, previous ectopic pregnancy that was treated with methotrexate, tubal ligation that was reversed. Okay. IUD use. Whole host of risk factors there. And so anything, just and drugs that cause, you know, the dysfunction in those fimbriae of the fallopian tubes. If they slow down, it can implant. Doesn't get, not able to push it down into the uterus. So how these patients present, it all depends on where it is, at what stage it is, if it's 4 weeks, 6 weeks, 8 weeks. Okay. And think about your fallopian tubes and the narrowed lumen. And if you have an implant, once it starts to get to about 8 weeks, that's when it's going to start stretching those fallopian tubes. Okay, and it's going to start causing pain. And yes, it can rupture those. Eliza.
When that happens, I know you said like it depends on where and like what stage, but do you like, I assume she had to have her bowel, part of her bowel resected.
Yeah, probably.
Is it ever like salvageable, like the tissue in which it embeds in, or do you always have, like, in fallopian tube, do you always have to take the whole thing?
Typically, yes. If they have to do surgery, then typically they remove the whole tube, especially if there's any evidence of rupture. Okay, and nowadays, if it's early enough, they can diagnose it with a transvaginal ultrasound along with your HCG level, then they can give you methotrexate, which it has an abortive effect. But you have to make sure and follow that HCG level and make sure it comes all the way down to 0. Okay, so ensure that it's not somewhere, or it's not still there, or maybe she had 2. Maybe there's still one in the pelvis somewhere. Yes, yes. You've got to watch the HCG level and make sure it comes all the way down to 0. So you're following that patient very, very closely. But yeah, if it's early enough, we can give methotrexate and it has the abortive effect. If it's ruptured, then you risk hemorrhage, especially if a uterine or tubal artery is involved. There can be significant blood loss, and that may have to be ligated and cleaned up. And blood itself is going to be cause scar tissue, and it's going to cause adhesions and then restrict the even more. Yeah. So typically they'll take that tube off. Once they take one tube out, then it decreases your ability to get pregnant by 50%. Okay, you alternate your ovaries each month for ovulation. And so you can only get pregnant every other month, potentially. Okay. So yeah, it's very dependent on where it is. But it's as the fetus grows and that the placenta grows, the amniotic sac grows, all of that. When does it outgrow its blood supply? When does it start to impinge on other structures? At what point? And at what point does it rupture, or the fetus not get enough blood flow and then die? And then you're gonna have dead necrotic tissue, which is then is gonna trigger an entire inflammatory response to clean up the debris. There's another video link in here for you to watch, which kind of goes through the whole process and how ectopics occur. We can take a look at it, or we can call it a day. Your choice.